We are initiating a rigorous analysis of the biological variables that modulate how a pharmaceutical compound transitions from its administration site into systemic circulation. This exploration requires us to examine specific cellular and organ-level mechanisms, such as surface area availability and localized blood flow, which act as primary gatekeepers for a drug's bioavailability. Analyze how fluctuations in gastric emptying rates or regional pH gradients can fundamentally shift the kinetic profile and passive diffusion of a therapeutic agent. Our objective is to systematically deconstruct how these internal physiological environments dictate the overall rate and extent of drug absorption. Analyze the drastic physiological transition as pH values drop from 6.8 in the oral cavity to a highly acidic 1.0 within the gastric environment, which fundamentally alters drug ionization states and solubility. Why does the small intestine function as the primary powerhouse for absorption compared to the stomach? Its expansive surface area and neutralizing pH of 5 to 7.5 facilitate the uptake of nearly every chemical class, whether lipophilic, acidic, or basic. Pinpoint the hepatic portal vein's role as a biological gatekeeper that channels absorbed substances through the liver for intensive first-pass metabolism before they reach systemic circulation. Distinguish this from the oral and rectal routes, which provide specialized access points to circumvent the liver and maintain higher concentrations of the parent drug in the bloodstream. Does the significantly reduced surface area in the large intestine explain why it contributes less to total absorption despite its favorable alkaline pH? Examine the gastric environment, where a restricted surface area of only 0.1 to 0.2 square meters establishes a physical bottleneck for systemic absorption. The intense acidity, fluctuating between pH 1 and 3, maintains acidic drugs in a lipophilic, unionized form that favors passive diffusion across the membrane once solubility is achieved. Simultaneously, this proton-rich environment acts as a chemical catalyst for the dissolution of basic drugs, though their resulting ionized state significantly impedes their passage into the bloodstream at this specific site. How does this precise interplay between solubility and ionization state determine whether the stomach functions as a facilitator or a barrier for a specific chemical compound? Focus your attention on the data table, specifically the surface area of 0.1 to 0.2 square meters, which reveals why the stomach cannot compete as a primary absorptive organ. While a transit time of up to 5 hours seems generous, the histological dominance of mucus-secreting cells acts as a functional filter, favoring protection over permeation. Notice how the blood flow rate of 0.15 liters per minute serves as a kinetic bottleneck, maintaining a lower concentration gradient compared to more vascularized regions. Why do these specific physical dimensions, including the 20-centimeter length and 15-centimeter diameter, prevent the rapid contact required for efficient molecular transfer? Ultimately, the stomach functions as a chemical processor, where the limited mucosal exposure dictates a secondary role in achieving systemic bioavailability. Observe the astronomical jump in surface area to 200 square meters, a magnitude achieved through a hierarchy of anatomical amplifications within this 285-centimeter stretch. This structural expansion begins with the folds of Kirkring providing a threefold increase, which is then compounded by the finger-like villi that amplify the area by a factor of 30. The final, most significant mathematical surge comes from the microvilli, which collectively result in a staggering 600-fold increase in available membrane space. Consider how this geometric complexity transforms the organ into the ultimate absorptive engine by maximizing the contact probability between drug molecules and the intestinal mucosa. This dense landscape of projections effectively eliminates the physical bottlenecks encountered in the gastric environment. Notice the mathematical escalation as we move from a smooth cylinder to a highly complex landscape, starting with the folds of Kirkring, which triple the initial 0.33 square meters of area. Observe the villi next. These projections provide a 30-fold relative increase, pushing our total surface area to 10 square meters. The most profound shift occurs at the microscopic level, where the brush border of the microvilli creates a 600-fold amplification, resulting in a final staggering 200 square meters of membrane. This geometric strategy acts like a molecular net, ensuring that every drug particle has the highest statistical probability of colliding with an absorptive surface. Can you see how this hierarchical scaling overcomes the physical limitations of the organ's 285 centimeter length? Shift your focus to the kinetic advantage of slow peristaltic movement, which dictates a residence time between 3 and 6 hours within this absorptive powerhouse. This extended temporal window ensures that molecules remain in contact with the membrane long enough for significant passive or active transport to occur. Simultaneously, evaluate the histological composition of the intestinal epithelium, which is specialized for high permeability through a dominance of absorptive cells. Unlike the mucus-heavy gastric lining, this cellular landscape is optimized to facilitate the rapid transit of solutes across the barrier and into the bloodstream. How does this combination of prolonged exposure and specialized cellular architecture solidify the small intestine as the most efficient site for drug delivery? Look at that blood flow rate of 1.0 liter per minute, which represents a massive 6 to 10-fold increase over the gastric supply. This rapid perfusion ensures a steep concentration gradient by whisking absorbed molecules away from the membrane immediately. The pH range of 5 to 7.5 functions as a critical chemical sweet spot, allowing a broad spectrum of both acidic and basic compounds to exist in their lipophilic, unionized state for maximum permeability. When you combine that 200 square meter surface area with a 3 to 6 hour transit window, you see a biological engine designed for exhaustive extraction. This specific convergence of high-velocity perfusion and a chemical environment that suppresses ionization is exactly why the small intestine serves as the universal gateway for almost all drug classes. Despite a neutral pH of 5.5 to 7 and a remarkably long residence time of up to 12 hours, why does the large intestine fail as an absorptive organ? The critical limitation lies in the complete absence of villi and microvilli, which collapses the total mucosal surface area to a mere 0.15 square meters. Contrast this microscopic area with the 200 square meters observed in the small intestine. Even with a 110 centimeter length, there is simply no specialized architecture to facilitate efficient molecular transfer. This structural deficit renders drug absorption practically insignificant, regardless of how long the compound remains within this neutral environment. The intestinal epithelium presents a dual-route challenge for drug molecules. They must either penetrate the cellular body itself or navigate the microscopic gaps between adjacent cells. Focus on path 1, the paracellular route, where small hydrophilic molecules bypass the cell by diffusing through the aqueous-filled tight junctions that bind these enterocytes together. In contrast, the transcellular pathways labeled 2, 3, and 4 require a molecule to cross the lipophilic apical membrane, move through the cytoplasm, and exit via the basolateral membrane. This transcellular journey is governed by the molecule's ability to partition into the lipid bilayer, whereas the paracellular route acts as a molecular sieve, restricted by the physical dimensions of the junctional spaces. Which route do you think a highly lipophilic compound would prioritize to reach the systemic circulation efficiently? We are now categorizing the specific mechanical pathways drugs utilize to penetrate the lipid bilayer, starting with passive diffusion, which relies entirely on the concentration gradient. Carrier-mediated transport introduces a layer of complexity, where specialized proteins act as biological shuttles. Specifically, note the distinction between active transport, which consumes ATP to pump molecules against their gradient, and facilitated diffusion, which merely provides a channel for assisted movement. Beyond these, we must account for vesicular transport for bulk movement, convective transport through aqueous pores, and ion pair formation, which chemically masks a molecule's charge to enhance its lipophilicity. Observe the technical diversity here. Do you see how a drug's specific chemical structure dictates whether it will passively slip through the membrane or require a high-energy carrier system? Look at this visual representation of passive diffusion, where the sheer chemical pressure of a high-concentration system forces molecules to seek equilibrium in a region of lower density. This process is purely spontaneous and defined by the fact that no external ATP or cellular energy is consumed. Instead, the inherent thermodynamics of the system dictate the molecular flow. You must recognize that the absolute driving force here is the concentration gradient, which functions as the mathematical difference between the high density on the mucosal side and the low density in the circulating blood. Since the blood acts as a continuous sink by whisking molecules away, it preserves this gradient. How does this persistent imbalance facilitate the steady-state transfer of molecules across the lipid bilayer? Active transport represents a fundamental shift in thermodynamics because molecules are forced to move against their concentration gradient, transitioning from an area of low density to one of high density. To achieve this uphill movement, the cell must perform metabolic work, fueled specifically by the hydrolysis of ATP to overcome the natural resistance of the gradient. This mechanism utilizes a specialized membrane protein that binds the drug to form a transient carrier drug complex. The protein then undergoes a mechanical shift to shuttle the cargo across the bilayer before releasing it on the other side. Because these protein carriers are finite in number and chemically precise, the entire system is saturable and structurally selective, meaning it operates like a dedicated key and lock mechanism that can reach a maximum processing capacity. How does this energy-dependent selectivity differentiate a drug's absorption rate from the simple, non-saturable flow we see in passive diffusion? Examine the stark contrast between these two kinetic profiles. The green line, representing simple diffusion, shows a direct linear relationship where the rate of transport escalates indefinitely as concentration increases. In contrast, the red curve for carrier-mediated transport reveals the phenomenon of saturation, where the rate eventually plateaus at Vmax because the finite number of available protein shuttles are working at their absolute maximum capacity. Pay close attention to Km on the x-axis, which marks the precise concentration needed to achieve half of that maximum transport rate, effectively measuring the affinity between the drug and its carrier. While simple diffusion is non-saturable, this carrier-mediated system is strictly governed by Michaelis-Menten kinetics, meaning that once you hit that Vmax ceiling, adding more drug will not accelerate absorption further. Facilitated diffusion serves as a specialized hybrid mechanism, where transmembrane carrier proteins assist drug molecules in moving strictly down their concentration gradient without any metabolic energy expenditure. Unlike active transport, the thermodynamic drive originates entirely from the high to low density differential, meaning no ATP is consumed to power the movement. Observe how the carrier proteins function as gatekeepers. Their specific binding sites ensure the process is structurally selective, accepting only molecules that match their chemical geometry. Because these protein carriers exist in finite numbers, the system is inherently saturable, meaning the rate of absorption will eventually hit a plateau once all binding sites are occupied. Does the requirement for a physical binding event explain why this process exhibits the same Michaelis-Menten kinetics we observe in enzymatic reactions? Analyze the mechanism of pore or convective transport, where specific transmembrane proteins create permanent, aqueous-filled conduits that span the entire lipid bilayer. These protein channels allow very small polar molecules, such as urea, water, or simple sugars, to bypass the hydrophobic interior of the cell membrane entirely. Notice how the transport rate increases significantly within these specialized pores. Why would a small molecule prefer this aqueous cath over the laborious process of partitioning into the lipid phase? This rapid transit is dictated by molecular dimensions rather than lipophilicity, making these pores high-velocity bypass lanes that facilitate a kinetic advantage for molecules small enough to fit through the narrow protein geometry. Observe how the plasma membrane acts as a dynamic physical barrier that can remodel itself to move massive cargo via vesicular transport. Phagocytosis utilizes these pseudopodia to surround and internalize solid macromolecules, while pinocytosis involves the membrane indenting to capture extracellular fluids and solutes into smaller vesicles. Contrast this with exocytosis, where the cell effectively reverses the process, fusing internal secretory vesicles with the outer membrane to expel materials into the extracellular space. Since these mechanisms involve the translocation of large volumes or particles, how does this energy-intensive engulfing bypass the size limitations of the protein channels we analyzed earlier? Strong electrolyte drugs face a significant barrier because they maintain a persistent electrical charge across the entire physiological pH spectrum, which severely limits their ability to penetrate lipophilic membranes. We can strategically overcome this by linking an ionized drug with an oppositely charged ion to create a temporary electrically neutral ion pair. This chemical association masks the charge, effectively increasing the complex's lipid solubility and allowing it to diffuse across the bilayer far more efficiently than the lone charged molecule could. Why does the pairing of a compound like propranolol with oleic acid fundamentally redefine that drug's capacity to navigate the hydrophobic core of the cell membrane? Examine these 4 distinct molecular pathways that define how a therapeutic compound penetrates the cellular barrier. In passive diffusion, the concentration gradient serves as the sole engine for movement, allowing lipid-soluble molecules to slip directly through the bilayer. Contrast this with active transport, where the cell must expend metabolic energy in the form of ATP to force molecules against their gradient via a specific carrier protein. Facilitated transport also utilizes carrier proteins, but operates strictly down the gradient without energy, while pore transport provides high-speed aqueous bypasses for small polar solutes. Which of these mechanisms do you suspect would be most susceptible to reaching a saturation point when drug concentrations are extremely high? This visual summary encapsulates the thermodynamic realities of molecular transit, where passive diffusion is represented as a spontaneous descent from high to low concentration without any external aid. In facilitated transport, specialized membrane proteins streamline the journey down that same gradient, increasing efficiency while still remaining energetically passive. In stark contrast, active transport is shown moving in the opposite direction, forcing molecules uphill against their natural gradient, which necessitates the consumption of metabolic fuel to drive the process. Observe the orientation of these slopes and consider why a drug molecule requiring active transport would be far more vulnerable to metabolic inhibitors than one following the passive descent. Evaluate this comprehensive matrix, where we categorize transport based on its energetic and structural requirements. While 3 of these pathways move with the concentration gradient, only active transport possesses the metabolic machinery to force molecules uphill against that gradient. Notice the correlation between carrier involvement and the saturation point. When a finite protein shuttle is required, as seen in both active and facilitated transport, the system becomes both selective and limited by its own capacity. Why does pore transport utilize a protein carrier but avoid the saturation and selectivity constraints that define the other 2 carrier-mediated systems? This data proves that proteins can function as either simple open conduits or highly regulated gates, depending on whether the drug molecule must be specifically recognized or simply pass through an aqueous space. Focus on the mathematical expression dq over dt equals dak Cgi minus Cp over H, where dq over dt defines the instantaneous rate of drug absorption over time. In the numerator, we find that the diffusion coefficient d, the surface area A, the partition coefficient K, and the concentration gradient, Cgi minus Cp, all exert a direct positive influence on the speed of molecular movement across the barrier. Pay close attention to the denominator H, which represents membrane thickness, because this value is inversely proportional to the rate. Any increase in the physical distance a molecule must travel will fundamentally stifle its absorption velocity. By integrating these variables, we can mathematically predict why the high surface area of the duodenum facilitates rapid uptake, while the increased thickness of glial cells in the blood-brain barrier acts as a potent kinetic filter. How would a drug's absorption profile shift if we were to significantly increase its lipid solubility, K, while the membrane thickness, H, remained unchanged? We are now broadening our focus to the specific physiological variables that act as macro-level regulators for the transport mechanisms we just mastered. Intestinal motility and the gastric emptying rate serve as the primary chronological clocks, determining the precise temporal window a molecule has to interact with the absorptive membranes before being moved along the tract. Beyond mechanics, we must analyze how localized blood perfusion and the biochemical composition of the gastrointestinal content can either facilitate or obstruct a compound's passage. Finally, consider the critical impact of age and pre-systemic metabolism, which dictate how much of the original dose survives hepatic and intestinal enzymes to reach the systemic circulation. Which of these 6 factors do you think would most drastically fluctuate in a patient experiencing a hypermetabolic state? Intestinal motility serves as the kinetic clock of the gastrointestinal tract, determining the specific residence time required for a drug molecule to interact with the absorptive epithelium. When hypermotility occurs, the transit velocity increases so drastically that the residence time collapses, leading to a significant drop in the probability of successful molecular transfer. Contrast the transit kinetics of a fasting state, which typically spans 4 to 8 hours, with a fed state, where the presence of food extends this window to 8 to 12 hours. Does this 4-hour temporal expansion in the fed state provide a substantial enough advantage for drugs with slow diffusion rates to reach their therapeutic threshold? Or does the increased residence time simply expose the drug to more degradative enzymes before it can ever reach the bloodstream? As we increase the starting volume, we see a corresponding surge in the initial gastric emptying rate due to the increased pressure on the pyloric sphincter. This contrasts sharply with the concentration-dependent inhibitory signals triggered by macronutrients like triglycerides and amino acids, which effectively downregulate the rate to allow for systematic processing. When evaluating the physical state, the lack of mechanical resistance in solutions and suspensions yields a much higher emptying velocity compared to the structural complexity of solids. Does the rapid transit of liquid formulations suggest that the stomach prioritizes the clearance of non-viscous fluids to maintain osmotic balance? Analyze the pharmacological and miscellaneous modulators that dictate the speed at which the stomach clears its contents. Anticholinergics and narcotics drastically suppress the gastric emptying rate by inhibiting gastrointestinal motility, while metoclopramide provides a prokinetic surge that forces more rapid transit into the duodenum. Physical variables like high viscosity and a left-side body orientation create mechanical and gravitational resistance that slows this process, effectively extending the drug's residence time in the gastric environment. Furthermore, observe how systemic conditions like hyperthyroidism or aggressive emotional states heightened autonomic or metabolic activity to accelerate emptying, whereas diabetic complications cause the rate to plummet. Does the fact that ethanol inhibits this rate suggest a significant hurdle for achieving rapid peak plasma concentrations of co-administered oral medications? Accelerated gastric emptying becomes a biological necessity when dealing with acid-labile molecules like penicillin G, as prolonged exposure to the stomach's proton-rich environment would trigger rapid chemical degradation. This kinetic speed is equally vital for enteric-coated systems, which are specifically designed to remain intact until they encounter the neutralizing pH gradients of the duodenum to begin their dissolution process. In cases where the small intestine holds the highest density of specialized transporters, such as for vitamin B12, the rate of stomach clearance directly dictates the onset and efficiency of systemic uptake. Consider the biochemical stakes here. If transit slows down for a drug that is unstable in acid, does the therapeutic window effectively close before the molecule ever reaches the absorptive mucosa? Observe how the splanchnic circulation claims 28% of the total cardiac output, a volume that intensifies after meals to maintain the steep concentration gradient required for rapid drug removal into systemic circulation. When mesenteric blood flow is hindered by conditions like congestive heart failure, the resulting decrease in removal rate forces a direct mathematical reduction in the drug's overall bioavailability. Contrast this with the lymphatic system, which acts as a specialized bypass for lipophilic and poorly soluble molecules, allowing them to enter the bloodstream while completely evading the liver's intensive first-pass metabolism. Even for inherently water-soluble compounds like eclerorubicin, utilizing liposomes or solid lipid nanoparticles can redirect their absorption through this lymphatic channel to maximize their therapeutic reach. Why would we prioritize this lymphatic route over the high-volume blood flow of the mesenteric vessels when designing a drug with high hepatic clearance? The presence of food acts as a chemical variable that can multidirectionally shift absorption kinetics, either by enhancing solubilization or creating physical and chemical barriers. Take griseofulvin, for instance. Fatty acids trigger a bile surge, releasing surfactants that essentially act as molecular detergents to solubilize this lipophilic drug for better uptake. Conversely, while penicillin sees a total reduction in absorption extent, compounds like aspirin and NSAIDs primarily suffer a decrease in absorption rate, a trade-off we often accept to minimize direct mucosal irritation. Given these drastic fluctuations, how do we justify the pharmacokinetic rule that taking a dose 30 minutes before or 2 hours after a meal effectively bypasses these food-drug interference patterns? A significant reduction in the gastric emptying rate forces drugs to linger in the stomach, leading to the chemical degradation of acid-sensitive molecules like penicillin, or stalling the transit of enteric-coated systems meant for the intestine. The resulting high viscosity environment further complicates matters by inhibiting the kinetic movement of solvent molecules, which effectively prevents the drug from reaching its dissolved state. Most critically, observe the formation of insoluble complexes, such as the tetracycline calcium pair, which creates a large molecular precipitate that is mathematically impossible to absorb across the epithelial barrier. Does the combination of these mechanical and chemical barriers explain why the timing of food intake is such a decisive factor in achieving a drug's required therapeutic concentration? Increasing the volume of co-administered fluid provides a dual kinetic advantage by simultaneously accelerating the molecular dissolution rate and triggering a rapid gastric emptying response via mechanical distension of the stomach walls. Notice how this shift in fluid dynamics directly enhances the absorption of compounds like erythromycin, which requires swift transit into the small intestine to achieve peak plasma concentrations. This rapid clearance not only optimizes uptake but serves a critical biological role by reducing the residence time of potentially irritating chemicals against the gastric mucosa. Does the direct relationship between liquid volume and transit velocity imply that the simple act of hydration could be the decisive variable in overcoming a drug's inherent solubility limitations? Mucin, the protective glycoprotein layer lining the gut, functions as a chemical trap for drugs like streptomycin and quaternary ammonium compounds, effectively retarding their movement toward the absorptive membrane. Conversely, bile salts act as natural surfactants that facilitate the solubilization and uptake of lipophilic compounds, such as vitamins A, D, E, and K, as well as griseofulvin. You must account for the chemical divergence where these same bile salts react with aminoglycosides like neomycin and kanamycin to form large water-insoluble complexes that cannot be absorbed. Does this dual functionality of bile salts, acting as both a solubilizing agent and a complexing inhibitor, suggest that the chemical charge of a drug molecule is the ultimate predictor of its fate in the gastrointestinal environment? Analyze how the presence of polyvalent metal ions like calcium, aluminum, or magnesium triggers a complexation reaction with drugs such as tetracycline, effectively locking them into large, insoluble molecular structures that are physically incapable of crossing the intestinal membrane. Beyond physical binding, we must account for the chemical shift caused by co-administering antacids, like sodium bicarbonate, which elevates the gastric pH away from its naturally acidic state. Since weekly basic drugs rely on this acidic environment for efficient dissolution, this neutralization forces the drug into a precipitated state, fundamentally slashing its dissolution rate. If a drug is physically trapped in a metal complex or chemically prevented from dissolving due to pH fluctuations, how could it ever reach the systemic circulation in a therapeutic concentration? Age-related physiological development dictates drug kinetics, beginning with the fact that infants possess a remarkably high gastric pH ranging from 4 to 6. This decreased acidity creates a significant chemical shift that can enhance the stability of acid-labile drugs, while simultaneously hindering the dissolution of weakly acidic compounds. Beyond pH, we must account for the underdeveloped anatomy, where both the available intestinal surface area and the volume of blood flow to the gastrointestinal tract are substantially lower than in adults. Why would this combination of a smaller absorptive membrane and slower vascular clearance necessitate a complete recalibration of neonatal dosing regimens to avoid toxicity? Let's investigate how the physiological aging process alters the kinetic landscape, starting with the significant deceleration of the gastric emptying rate. This mechanical slowdown is compounded by reduced peristaltic movement, which mathematically increases the total residence time within the gastrointestinal tract. Furthermore, evaluate the impact of decreased intestinal blood flow. How does this drop in perfusion pressure disrupt the concentration gradient required for efficient molecular transfer? These combined variables transform the gut into a high-resistance environment, potentially delaying the onset of action and complicating the predictable absorption profiles we see in younger populations. We are now confronting the physiological gatekeeper known as the first-pass effect, or pre-systemic metabolism, which acts as a primary biochemical filter for orally administered compounds. This phenomenon involves the enzymatic chemical transformation of a drug molecule as it traverses the intestinal wall and the liver, essentially neutralizing a portion of the dose before it can ever achieve systemic distribution. Notice how this process dictates the bioavailable fraction. The more aggressive the metabolic conversion, the lower the final concentration of the active parent drug in the bloodstream. If a molecule is highly susceptible to these localized enzymes, how does that mathematically force us to adjust the initial dose to ensure a therapeutic response survives this initial hepatic and intestinal clearance? Observe the kinetic divergence between intravenous administration, which guarantees 100% systemic bioavailability, and the oral route, which forces the drug through the liver's metabolic filter before it can circulate. By utilizing sublingual, inhalational, or intramuscular routes, we bypass the hepatic portal vein entirely, preventing the premature enzymatic degradation that characterizes the first-pass effect. Because the oral route results in a significant pre-systemic loss, how does this mandatory hepatic transit fundamentally limit the fraction of the parent drug available for the rest of the body compared to direct systemic entry? For a molecule with an exceptionally high hepatic extraction ratio, would you select the oral path that risks significant inactivation or a bypass route to preserve the chemical integrity of your dose? Trace the metabolic gauntlet depicted here, where an oral dose must survive two extracellular threats: Path 1, involving intestinal and pancreatic luminal enzymes, and Path 2, which represents chemical alteration by bacterial enzymes in the colon. As the drug partitions into the mucosa, Path 3 highlights the enzymatic resistance within the gut wall itself, a cellular filter that metabolizes molecules before they even reach the portal vein. The final hurdle is the liver, or Path 4, where first-pass hepatic metabolism utilizes a dense array of enzymes to chemically transform the compound one last time. By the time the substance finally reaches systemic circulation, do you realize how these 4 cumulative metabolic losses have mathematically slashed its total bioavailability? These digestive luminal enzymes perform critical chemical transformations, such as when hydrolases specifically target ester-based drugs like chloramphenical palmitate to cleave the bond and release the active, therapeutically potent chloramphenical molecule. In contrast, peptidases present a biochemical barrier by attacking amide linkages, which effectively dismantles and inactivates protein and polypeptide drugs before they can reach the epithelial surface. Why do we consider the colon a strategic sanctuary for peptide delivery? Because this distal region lacks the aggressive peptidases found in the upper tract, providing a protected environment for these sensitive molecules to maintain their structural integrity for eventual systemic uptake. Look at the dramatic escalation of microflora concentration as we move toward the colon, which establishes this distal region as a massive bioreactor for drug biotransformation. Microbial enzymes can fundamentally alter a drug's pharmacological profile, as seen in the hydrolysis of sulfasalazine. Here, the bacterial enzymes break the parent molecule down into sulfapyridine and 5-aminosalicylic acid, transforming an inert compound into its active therapeutic form. In sharp contrast, examine the reduction reaction of digoxin into dihydrodigoxin, where the specific chemical addition of hydrogen by bacterial metabolism results in a complete loss of clinical activity. Given these opposite outcomes, activation versus inactivation, how would a patient's unique colonic bacterial population influence the final systemic concentration of their prescribed medication? Move your focus inside the very tissue of the gastrointestinal lining, where mucosal enzymes provide a critical cellular barrier spanning from the stomach all the way down to the colon. A prime example of this local defense is alcohol dehydrogenase, or ADH, which is strategically embedded within the stomach mucosa to initiate the chemical inactivation of ethanol before it can ever cross into the bloodstream. By converting these molecules into metabolites right at the primary site of contact, these enzymes function as a metabolic filter that significantly reduces the final bioavailable concentration reaching the portal circulation. If the expression levels of these mucosal enzymes were to fluctuate, what mathematical impact would that have on the first-pass extraction ratio for an orally administered substrate? The liver serves as the ultimate metabolic crucible, where the cytochrome P450 enzyme system executes high-velocity chemical transformations on a wide array of substrates, including propranolol and nifedipine. While this first-pass effect often acts as a subtractive process by inactivating molecules, consider the constructive role it plays for prodrugs like codeine. Through a precise demethylation reaction, the liver converts this inactive methylmorphine into pharmacologically active morphine proper, essentially turning the metabolic barrier into a chemical activator. How does this specific dependence on P450-mediated catalysis explain why the oral bioavailability of these drugs can vary so drastically between patients with different hepatic enzyme profiles? Certain dietary components can act as potent biochemical inhibitors, fundamentally altering a drug's pharmacokinetics by neutralizing the metabolic enzymes responsible for the first-pass effect. For example, grapefruit juice contains furanocoumarins that specifically disable the intestinal cytochrome P450 isoform known as CYP3A, which serves as a primary gatekeeper for many oral medications. When this enzymatic barrier is compromised, drugs that would normally be heavily degraded before reaching the heart enter the systemic circulation in much higher concentrations than intended. This sudden, unregulated surge in bioavailability drastically shifts the compound's plasma concentration toward the toxic range, illustrating how a simple food interaction can dismantle the body's primary defense against drug overdose. Why would an inhibitor that only targets intestinal enzymes still pose such a massive risk for drugs that also undergo extensive hepatic clearance? We have successfully integrated the complex hierarchy of physiological filters, from the logarithmic pH shifts in the gastric environment to the massive 600-fold surface area expansion provided by intestinal microvilli. This rigorous analysis has demonstrated that systemic bioavailability is not a static property, but rather the cumulative mathematical result of competing variables like the first-pass extraction ratio and the kinetic limits of carrier-mediated transport. How would you now prioritize these biological bottlenecks when predicting the final plasma concentration for a drug susceptible to both acid degradation and high hepatic clearance? Our comprehensive exploration of these anatomical and biochemical barriers confirms that mastering the interplay between cellular architecture and enzymatic metabolism is the only way to truly engineer precise therapeutic outcomes.